Good evening, sir. It's both an honor and a privilege to welcome you all to E-Gurukul Series 2, Episode 8 of our continuing medical education series. Today's session promises to be both enlightening and practically relevant as we delve into a critical topic in obstetrics, induction of labor, current concepts. To guide us through this complex and evolving subject, we're extremely fortunate to have with us distinguished expert Dr. P C Mahapatra. Dr. Mahapatra is a name that resonates with excellence in the field of obstetrics and gynecology. With decades of clinical experience, academic contribution, and a deep commitment to maternal health, he has been a guiding force for countless clinicians and students alike. His insights are rooted not just in textbook knowledge but in years of hand on experiencing managing challenging clinical scenarios with compassion and precision. His leadership in advancing women's health and his contribution to medical education have been made a lasting impact on the field. Today, he will be shedding light on the evidence based practices and detailed clinical consideration related to the induction of labor, a topic that lies at the intersection of safety, timing, and outcome optimization for both mother and child. Please join me in extending a warm welcome to Dr. P C Mahapatra as he takes us through this important session on induction of labor current concept. Good evening, sir.
Good evening. Thank you, Sefali, for your brilliant introduction and overestimating me. Well, Team Juventus, I really owe you a lot for this academic endeavor for not only me, but across the countries, the Foxians, the gynecologists, obstetricians, clinicians, postgraduates, and everybody. I think I'm able to share them with this E-Gurukul program. And welcome to this particular series of second series and 8th episode. Today we are having it. And I bring greetings from the place of Lord Jagannath, always as usual. And I cannot do anything without the help of the divine blessings of this great Lord. And therefore, again, I welcome all of you, my viewers, my obstetricians across the country, and my postgraduates on this second series of Induction of Labor, the current concepts, and again thank Team Juventus for the Juventus initiative for that. So this is a series 2, episode 8, a common topic for the clinicians, for the obstetricians who have, I think, were gradually losing their art of obstetrics, the dying art of obstetrics. For that, I'm again reviving on that particular topic, induction of labor. And on a clinician's perspective, what should be the role of the practicing obstetrician for that? And therefore, this is a very common topic, and for not only for the postgraduates, but for the clinicians in this scenario, when the incidence of cesarean has been increasing, when the defensive practice has come up in a view, and where our beneficiaries want a 200% outcome, good outcome as far as the mother and baby are concerned. Where we stand now, let's analyze in the technical manner how scientific we can do that in the present context of induction of labor. Now, these are some of the hard facts. Induction of labor is one of the most abused procedures in obstetric practice, and it has continued since long when the old obstetricians are practicing obstetrics, particularly masterly inactivity and watchful expectancy. Now, there is a world over, there is a really concern about the increasing rate, cesarean section rate. And I think in this scenario, if you want to introspect yourself to decrease the cesarean rate, I think induction of labor is definitely important for that. But because of increased cesarean section rate, simultaneously the induction of labor has a declining trend in modern obstetrics. and the new generation of the obstetricians feel much better with the operative delivery than the vaginal delivery for that. For various reasons, this should be there. And if you want to have an induction of labor, I can assure that if in the minds of the obstetricians, induction should be considered for that, we are definitely going to have a decrease in the primary cesarean section rate, and which is very, very vital for that. Because primary cesarean section rate, if you reduce it, I think ultimately the overall prevalence of the cesarean section rate will be reduced for that. There is no doubt about it. One of the most important, we are scientific people, and basing on the science and the judgment, indications should be genuine and depends on individual judgments for that also. That should be based on some values, scientific values for that. There are various indications now. I will deal with the subsequent slides, but social indications, programmed labor, and indications for convenience has emerged during the recent periods for that. For the last few years, we are finding this as one of the place, and it becomes a debatable issue for that also. Efficacy and consequences are two important determinants for induction for that. Any method you use it should be effective, it should have a minimum complications, and the consequence should be a good perinatal and maternal outcome for that. These are the main thing for that, and ultimately, if this is achieved, we say that yes, we are getting the results with that and we are happy about it. Availability of newer oxytocics has now transformed the meddlesome delivery in the past. In the past, when we imagine when we were students also, effective oxytocics are not available for that. Now, the newer oxytocics by researcher has really transformed this delivery process over the past for that to a considerable extent for that. Counseling is a very important part nowadays. Counseling, participatory obstetric practice, and dedicated obstetric units are of paramount importance for that. Now, why I mean to say participatory obstetric practice? Because I have seen the evolution of obstetric practice. Once upon a time, it was a prescriptive practice. You prescribe and give an opinion that you require cesarean section, or you require vaginal delivery, or you require induction of labor. And without any question, the party or beneficiary agrees to it also. Then came an era of participatory obstetric practice. We know that they are intelligent people, they're educated, and we must participate. What are they going to do? Say, for example, if you decide for induction of labor, you should say, what is the problem? Why you want to induce me? Why you want to have a vaginal delivery? I think that must be very well conveyed to the party, and this is known as a participatory obstetric practice for that. But nowadays, at times we feel that it has become a directive obstetric practice. The party and the people and the beneficiary insist about the decision also. You do cesarean section, you allow vaginal delivery at any cost for that, even if it is contraindicated. That becomes really changing the situation and putting us in a Damocles sword for that also. Now, for all these, obstetrics is a 24/7 business, and a dedicated obstetric units are a paramount factors for that. And that is the beginning for that. When you are going for an induction of labor and you are dedicated and committed till the delivery, that you should be there. There should be a 24/7 services, emergency services, along with the operative interference. If at all cesarean section is required, you must do it with additional NICU facilities for that also. Now, certainly it's a way forward for reducing primary cesarean section rate, as I have already mentioned about it, and that way we can reduce the cesarean section rate. Now, whatever it may be, spontaneous onset of labor versus pharmacological initiation of labor, there is definitely a difference for that also. Because in the labor process, there are various factors which operate during this period for that. And we do not know many of these. I think the natural onset is definitely different than the pharmacological onset of labor by drugs for that. There is no doubt about it for that also. Now, medical legal issues and defensive obstetric practice are the limitations for that. And that's why at times we feel very difficult in decision making particularly whether you go for induction labor or cesarean section for that also, because of this medical legal issues and defensive obstetric practice for that. And this has now come up in a big way. Conceptual difference between induction of labor and augmentation of labor. I think there's a two term which is there. We ask the postgraduate, what is the difference between induction of labor is that you initiate the labor process, but augmentation of labor, suppose there is a delay in the latent phase of labor or delay in the first stage of labor. I think you accelerate the labor process by some agents, by some oxytocics for that, and that becomes an augmentation of labor. So over past few decades, what are the learning lessons for that? Let's see. Let's first understand what is the definition of this induction of labor. It's an intervention to initiate uterine contractions, aiming at vaginal delivery. Aiming at vaginal delivery. You may be able to do it, complete it, or you may not be able to commit it. But this is the method to initiate uterine contractions for vaginal delivery for that. And what for? It is the where the maternal and fetal benefits outweigh the risks. These are the real indications of induction labor, where you find the benefits of the mother and the baby is outweighing the risks out of it if it continued inside the uterus. Changing concepts is there, changing concepts, changing molecule is there, and genuine indications should be absolutely nine for that. And importance of counseling, I've already told about it, because the mindset of the patient is also very, very important for that, if you want to have a vaginal delivery for that. And it should have a right place. Obstetric units with 24/7 emergencies are the best ward for that. And right person for monitoring, she should be knowledgeable, either a midwifery or an obstetrician, whoever it may be, she must be rightly monitoring this particularly whole process of that. And coming to the methodology or methods, ideal methods, we will discuss at length what is available, what was in the past, and what are the changing concepts and what are the methods available for induction of labor. So why induction? Basically, there are four reasons why we are going to induction. First, anticipated benefits to the mother for them. Say, for example, there is an IUFD. I think anticipated, if you keep it, if you do not induce it, lot of mental strain will be there. This is one of the example I'm telling you, anticipated benefits to the mother. And second, suppose there is the estimated risk to the mother. Say, for example, PIH. The risk to the mother is maximum from a gestational hypertension. She may have a convulsion. She may have an eclampsia for that. Estimated risk to the mother is one of the indications for that. Anticipated benefits to the fetus. Say, for example, an IUGR, or when there is a color flow changes in the color Doppler. These are the case anticipated feed benefits to the fetus. Rh negative individual, GDM, these are for particularly for example for that. And estimated risk to the fetus when it has gone a way forward, a reversal of the block, I think risk to the fetus is there. Then induction of labor should be done. Abruption in early phase for that, or a severe hypertension giving rise to a placental insufficiency, severe degree of placental insufficiency are the estimated risk to the fetus. Now, when we come to the classic components of labor, there are four P's: power, passage, passenger, and the provider. All four, if they are normal, the vaginal delivery is possible, and normal labor is based on all these four varieties. Now, let us analyze what we can change, what we cannot change, what we have a control, and which we do not have a control. A passage. We do not have a control. Say, for example, if it is a contracted pelvis, the soft tissues and the bony pelvis, the passage, we cannot alter it. Passenger, again, we cannot alter the passenger. And therefore, we cannot change the passenger's attitude. We cannot change a dictate that the fetus will obey our commands for that also. That is not possible for that. The only two things we have a control. One is a power, another is a provider. And power, believe me, is a great boon for obstetrics in alleviating many of the complications arising out of the process of birth. And therefore, the power, the uterine muscle, I think there are agents where we can manipulate the power. We can initiate the muscular contractions by giving the molecule which is available now, pharmacological molecule or surgical methods or whatever it methods for that. So power, we can have some control and change. And of course, provider, we ourselves should be adequately knowledgeable and adequately skillful. And about the tricks of obstetrics, we must be very familiar if we are at all want to be an obstetrician and dealing with the topic of induction of labor. Now, coming to the mechanism of spontaneous labor, that is also important because when we consider about induction of labor, two things are important. In spontaneous labor, one is a cervical ripening, another uterine contractility. The normal process of pregnancy, in the whole duration of pregnancy, what happens? There is a uterus is quiet, calm, accepting the physiological contraction, and the cervix is closed. The ripening is not occurring. Cervix is closed till the desired time. When the process of labor starts, there is a changes in the cervix, there is a changes in the uterine contractility, contraction, relaxation, and retraction. These are the three main physiological processes involved in the process of labor. And these two are important. And while considering the induction of labor also, in pharmacological onset and not natural, in natural labor, what happens? This cervical ripening and uterine contractility, there are a lot of changes, few days or few weeks before onset of labor, which is responsible for making the cervix unfavorable to favorable, unripe to ripe. And initiation of the uterine contractions and segmentation of the upper uterine segment, lower uterine segment, upper uterine contraction segment contraction occurs, lower uterine segment dilates, and there is a gradient of uterine contraction from fundus to the cervix for that. This is how about the mechanism of spontaneous labor. And we should understand, if you adopt a particular reagent or a molecule, I think these two things are mainly dependent on that. And how it happens, cervical ripening and uterine contractility. There are a host of biochemical factors, enzymes responsible for that, and host of hormonal changes, starting from estrogen to progesterone to prostaglandins. These are all important for that also, to initiate labor process for that. And the receptor modulation. All these hormones have a definite receptor in the muscles. That receptor modulation should be there for the optimum results for that also. And there are some inflammatory factors which are available. An inflammatory process which is mainly mediated by the prostaglandins, and initiation of labor can occur for that. And there are many undetermined factors. There are many undetermined factors which we do not know. Science has not proved as far as the definite factor. That's why we do not know what is the cause of onset of labor. Till today, with advances, with the conceptual advances, we are not able to find out what is the exact cause of onset of labor. So besides these four biochemical factors, hormonal changes, receptor modulation, and inflammatory factors, there are many undetermined factors which we do not know for the onset of labor for that, and which determines the cervical ripening, and which determines the uterine contractions in a rhythmical and continuously, almost similar to the physiological process of natural onset of labor. Now coming to the evolution for that, let me brief you about the evolution, the history of this particular methodology of induction labor. Antiquity, when we go, at that time, the treatment recommended, the methods were massage of breasts and uterus. They find that the breast and uterus has a link for that, and mechanical massage of the uterus might liberate some of the agents which stimulate the uterine contraction for that. Then came the intracervical tents and boogies which are there, which helps in dilatation, and these are all hygroscopic boogies for that, and the laminaria tents were the initial period for that. Then the vaginal dose and enema. Enema also, we believe that yes, therefore in early onset of labor, shea butter enema is usually given to expedite the uterine contractions for that. Now, the class by itself is ARM. ARM is a class by itself. You believe today is 2025. I salute the great scientist Denman in 1756. He first found out artificial rupture of membrane, and that's a method of initiating the uterine contraction. And till today also, that is a much better method than whatever pharmacological method we are now available for that. And ARM has proved test of time for that. And that's why it was initially designated as an English method for long decades. Sure, you can please continue. Well, then came in ARM, there is a possibility of cord prolapse, there is a possibility of infection. Then 1931, Drew Smith catheter was used for hindwater rupture of membrane because of these two complications which is there for that. But subsequently in 1931, it is found out, and subsequently within a short time it got disrupted, and in the present scenario we are not favoring the hindwater rupture, excepting in a case where polyhydramnios is there. Even there also we are going for artificial rupture, forewater rupture for that. Now pitocin, the pharmacological agent, it is a posterior pituitary extract, was first found out, discovered in 1906, and Theobald in 1952, first used for induction of labor, and then subsequently in 53, it was a mixed. When it was used, the Theobald used it, it was not a pure pituitary extract. The vasopressin is combined with that, and that vasopressin has got some side effects for that, and therefore this purified and synthetic oxytocin was a desirable molecule which came out in 1953 for that. And Turnbull and Anderson in 1968 first found out how to give this pituitary pitocin for that, and a titration method, an intravenous titration method. Otherwise, the methodology, how you give it, what is the dose, and the methodology is not known. And this credit is gone to Turnbull and Anderson titration method. Till today also, we do it with the titration method for them. Now, subsequently, better oxytocin, effective oxytocin has come. Prostaglandins is one of the examples. In 1935, it was von Euler who found out the prostaglandins from the seminal fluid. And the seminal fluid, at that time, it was thought that this particular prostaglandin was from the prostate gland, and that's why it was named as a prostaglandin for that. But many of the tissues contains prostaglandins in the body, but subsequently it has been proved by that. And Elias Conway, 1970, first synthetic dinoproston formulated that for induction of labor. Beckstrom, Samuelson, Wayne, these are the three great scientists. They have contributed their whole life research on the different types of prostaglandins, and that's why they are awarded Nobel Prize way back in 1982 for that. Bishop and Calder, what is the role of this great man? 1974, these two people, Bishop found out a scoring system which determines the factor for successful induction. And this scoring system, you can predict it. The scoring system can predict about the outcome of the success for that also. And later on, Calder has modified the Bishop score. Instead of the percentage of effacement, the length of the cervix was included for that. Now, in the era when sonography came, I think sonographic assessment of cervix has become very, very important for that also. And the length of the cervix, the effacement, the dilatation, all these were clinical methods by doing a PV examination. So now, sonographic assessment of cervix is a non-invasive method where we can find not only the length of the cervix, but the width, the effacement can be very well judged with that. And that has aided to the clinical criteria for cervical findings. Now coming to the indications, broadly we find an obstetric and a medical indication for that. And I'm ignoring the third important thing, which is a debatable issue, the social indications or by convenience. Because regarding the, suppose some Baba and Mama tells that today you deliver it, I think Muhurtam they want it. It's a totally non-scientific and non-technical issues for that also. And obstetric and medical are mainly propounded for. But I cannot completely ignore that. Even if it is an obstetric and medical indication, the timing of induction is an important factor for that. The timing is important because the availability of the full team, obstetric team is important for that, and that has to be continued. That in the tower, in the working hours, I think there's a more important dedicated maternity unit, some dedicated people should be there who will be responsible for that. Now, obstetric and medical indications for that, these are number one common indications are prolonged pregnancy. And there are three very different terminologies I want to just clarify these few things. Prolonged pregnancy, post-dated pregnancy, that means cross the date, expected date. Post-term pregnancy from 37 to 42 weeks is a term, and beyond post-term, beyond 42 weeks is a post-term. And post-maturity, along with that, the maturity, the functions of the baby are more. That means along with the duration of that, the signs of post-maturity should be there. And perfect example, say weight of the baby should be grown for that. And that is a post-maturity for that. But as far as the induction of labor is concerned, I think where is the timing, where we decide whether a post-dated we do a induction of labor, whether at post-term after 42 weeks we do an induction of labor, or beyond that also post-maturity we'll do an induction of labor. I think I will just give a little hints for that also. Now, regarding this, the maturity is important, the fetal maturity. And there are a lot of scientific evidence, the studies which shown that the Asian women do have a 1 week's earlier maturity than the Western counterpart for that. So therefore we say our 39 weeks is a term. There are a lot of studies we say it's 39 weeks, it's not a 40 weeks which is source for that. And therefore we should not wait more than 42, 41 weeks for that. The recommendation now is that as we wait for more than 41 weeks, the affection of the fetus will be more, and the fetus, I think there will be the IUD, there could be some placental insufficiency, and there could be macrosomia, which is a real problem for that. And therefore, we have now in the present context, I will say that yes, 41 weeks is the time where we take it for that. And don't wait for 42 weeks. And for the clinicians also, I'm recommending it's unwise to wait for 42 weeks, even if the range of term is from 37 to 42 weeks, we should not wait for 42 weeks. And therefore, this is important. But at the same time, the gestational age should be determined accurately. And now, earlier, we are not able to find out the gestational age before the sonographic era for that. And therefore, before the sonographic era, we are mainly dependent on the last menstrual period, which is very variable for that. And I have seen cases of induction being done in a premature baby for that. Supposed 42 weeks, we find that by calculation, you induce it, and they're all premature babies for that. And that becomes a real problem. And therefore, now the question doesn't arise because sonography and fetal medicine has been an integral part of the obstetricians. And therefore, gestational age determination is important right from the early pregnancy for that. And that gives a very good thing. As we go on and down, second trimester, the variations is up to 2 weeks. And third trimester, the variation is up to 3 to 4 weeks. The identification of that, we are doing it 11 to 13 week scan or an early scan for fetal viability scan. From that day, accurate determination of the gestational age is important. Now, second important common complications are hypertensive disorders of pregnancy. Over the past few decades, we have been able to reduce the hemorrhagic deaths, but we are not able to change the hypertensive deaths. In other words, hypertensive disorders of pregnancy are really more prevalent than the other causes for that. And that is one of the indications hypertensive disorders for the maternal as well as for the fetal sake. Induction of labor or termination of pregnancy should be done for them. Intrauterine fetal death, IUFD. I think in fetal IUFD, at most, because of various reasons, IUFD can occur, or a grossly malformed baby. These are the two instances where termination is desirable for that. And termination at vaginal delivery is desirable for that also. Knowing that it is a fetal death or knowing that it's a gross congenital malformation, I think it is not wise to go for a cesarean section operative delivery, and therefore it is a maternal stress to the patient particularly for that. And therefore, the first priority should be a vaginal delivery, and therefore induction of labor is a very, very important part in this group of 2 cases of intrauterine fetal death or gross malformation of the fetus. And this is important for that. IUGR, placental insufficiency. When the IUGR occurs, again, IUGR, if it continues inside the pregnancy, the risk to the fetus by being in utero is more than the benefits of terminating the pregnancy and and taking care after delivery for that. And that is commonly the placental insufficiency with or without the maternal hypertension. There could be various causes for that. Early detection of IUGR is now very common by obstetric sonography fetal medicine specialists, and therefore these are the cases where you terminate it early before it goes to severe IUGR and severe placental intraplacental insufficiency, where it is not able to, fetus is not able to sustain the stress of labor for that, and therefore these are the cases. Otherwise they will go for IUFD for that. Oligamnias, again the oligamnias, the degree of oligamnias is important for that also. So when borderline cases of oligamnias, say around 8 or 7, I think it's a wise part for that. If you continue it's inside the uterus, I think ultimately the oligamnias, severe oligamnias, I think it's a threat to vaginal delivery where you can go for a cesarean section. But in these cases of cutoff limit of this particular oligamnias, I think there is a place for induction labor and aiming at vaginal delivery. Placental abruption, again placental abruption, either with living fetus or without living fetus, a dead fetus. Both, I think, if you do an ARM, the immediate delivery can be occurring there, and vaginal delivery is possible for these particular cases for that. Chorioamnionitis, the infection, chorioamnionitis, again, the risk to the mother if it is going for an operative delivery, and therefore chorioamnionitis also termination of pregnancy, and there is a place for induction labor. PROM and PPROM, this is also an indication for induction labor. I must say one thing, that when there is a premature rupture of membrane, the leaking membrane ruptures, it is also affecting the inside the uterine contractions. In a case of PROM, uterine contractions is initiated through the either inflammatory or through the prostaglandins for liberated for that. And we have seen about 80% of the cases after PROM, within 24 hours labor sets in and delivery occurs vaginally for that. And don't wait for too much time for infection, maternal or neonatal infection to continue, but there is a place of conservative management, wait and watch, and not beyond 24 hours for that also. And therefore PROM there is there. Second important aspect in PROM, now sonography is available and you do a sonography and you find that there is some optimum amount of liquor which is there for that. Say for example 7, 8, 9 liquor is there. At that particular stage you do an induction labor and complete the process for that. RH isoimmunization. I think RH isoimmunization, we know the fetal affection in RH isoimmunization, particularly in immunized, RH immunized pregnancy where the fetus is affected. There is a hemolysis and fetal affection is there. We can detect it by now sonographic assessment, and then we can do a termination of pregnancy earlier by induction labor or cesarean section for exchange transfusion afterward. Because if you keep it for a longer time there, again it is a risk to the fetus. It may culminate in intrauterine fetal death. Diabetes mellitus and GDM. Nowadays it's very common. Diabetes mellitus and GDM are very common, though we obstetricians are routinely doing in all antenatal period routine screening of GDM. We are doing it, but still this is there either with the pre-existing diabetes with pregnancy or GDM. I think apart from control of blood sugar, I think termination of pregnancy is desirable, because these are the cases as soon as we want the optimum fetal survival, say for example 36, 37 weeks, and we go more than that prolongation for the spontaneous onset of labor, we initiate that process for the fetal sake for that. And of course, I have told the debate regarding the social and convenience, social indications, convenience, program labor for that. Now, what are the successful induction? What are the factors responsible for successful induction? So, socio-demographic factors like age, relatively younger age group, parity is important, either a second para 2, second gravida or first primary gravida, this is important. If there is a previous vaginal birth, this is a successful induction group there. Even if it is a preterm or a mid-trimester abortion, I think this is a previous vaginal birth is again aiding to a successful induction factors for that and a prognostic factors for that. Gestational age, closer to the EDD, better is the successful induction. And away from the EDD, gestation. So more is the gestational age, successful outcome is the induction labor for that. Estimated birth weight is also important for that. Estimated birth weight and the station of the head is important. If the station of the head is low and estimated birth weight is optimum, I think for the fetal sec, I think we can go for the. If the birth weight is more, the macrosomia, I think induction resolve the failure will be there for that. So the estimated birth weight and eliminating macrosomia for that also. And most important is the cervical status. The cervical status, and first I salute today the Bishop and the modified Bishop score for the cervical status, maybe with supplemented with the biophysical methods of ultrasound. We know that the right cervix, if it is the right cervix, the induction, success of induction is more often there for that also. And therefore, the scoring system helps in predicting the outcome for that. And next is the methods. We'll deal with the various methods now and what are the different methods for the successful induction. It's an individual judgment depending on the particular patient, what method is suitable for that particular patient. When I deal with the different clinical scenario and solving clinical dilemmas, I think I will clarify these particularly. And this is again, I am highlighting the obstetric units, the team and the facilities. These are important factors for successful induction for that. And therefore, there is a need for 24/7 emergencies. There is a need for a dedicated obstetric units with a team, and the facilities should be there around the clock for which you can be able to do the induction procedure. This is an example of modified Bishop score of Calder. We showed the 3 pelvic score designed as a dilatation of cervix, length of cervix, station of the presenting part, consistency of the cervix, and the position of the cervix for that. And 6 to 12 scoring are favorable. If it is 0 to 5, it is unfavorable. And 0, 1, 2, 3 has been assigned to the dilatation of the cervix less than 1, 1 to 2, 2 to 4, and more than 4 centimeter. Length of the cervix 4, 0, 2 to 4, 1 to 2, and more than and less than 2. And station of presenting part -3, -2, -1 to 0, and +1. And position of the cervix either a posterior or a median anterior. And that's why we calculate this in this form. And 6 to 12 is the favorable score, and unfavorable is 0 to 5. Now, what are the contraindications for that? Malpresentations. Malpresentations is a contraindication for that, and particularly the transverse lie. Even with the dead fetus, transverse lie is a contraindication. In a dead fetus in a breech, yes, it could be given for that also. Malformation with breech, it can be dealt with that also. Malformation, a gross malformation like a Siamese twins are really contraindication for that. So malpresentation, low-lying placenta, major degree is a contraindication for that, absolute contraindication. Scarred uterus is the relative contraindication. There are 2 types of scar which can be there, a cesarean section scar or a myomectomy scar. You find out from the history and examination on the previous records whether it's a classical cesarean section. If it's a classical cesarean section, it is an absolute contraindication for that. If an myomectomy, the cavity is open, I think it's a absolute contraindication for that. A scarred uterus is important determining factor for the induction level. Pelvic structural defects or tumors, which doesn't allow the vaginal delivery, aiming at the vaginal birth is not possible. I think these are the cases where it is done. And previous repair of difficult vesicovaginal fistula, which is very rare nowadays, or previous repair of the pelvic, I think pelvic reconstructive surgery, we have done it. I think these are the cases where induction labor should be condemned for that. Maternal infections like herpes and HIV are the contraindications. And of course, gross IUGR, severe personal insufficiency, severe oligomnias. I think you aim at initiation of labor and the baby is not able to sustain the stress of labor for that. You can directly find out alternate methods of the operative delivery of cesarean section for that. Now methods, what are the different methods available? We have got a mechanical methods, we have got a surgical methods, and we have got a pharmacological methods for that. Coming to the mechanical methods, intracervical balloon device. Gone are the days where the laminaria tents are there, dilapan are there. We're not going for that. Synthetic dilapan, laminaria tents for that. intracervical balloon devices is there, and Foley's balloon is a cheap available thing. 30 ml you go it for that, and either simply mechanical or you can go for a easy. So extra amniotic installation of saline. Extra amniotic saline installation of varying, I think from 50 ml to 100 ml, 100 ml, you can give it for that. I think it's a very popular in a state like Kerala, and they are very much, I think, adopting this procedure for that. We have tried this particular. In some cases also we do the cervical priming, we do it with the cervical mechanical methods without the saline, or if it is there, the saline. But in cases of IUFD or gross congenital malformation, I think you can give Foley's with extramnionitic saline installation to about 50 to 100 ml for the particular for that. That becomes an easy process in comparison to the pharmacological methods like a misoprostol or any prostaglandins for that also. One of the complications if that don't if it is retained for a longer time, I think the chances of infection could be there also. Now, there are some recent publications also regarding this mechanical methods. Even not one Foley's, 2-3 Foley's simultaneously they can give it for that, for the cervical priming for that, and that has been also recommended now in the current literature also. They're demonstrating this, emphasizing on these mechanical methods for that. Surgical methods, age-old sweeping of membranes. We are doing it earlier also. Whenever we are examining in the antenatal period at 37 weeks, when the patient comes in a primigravida, when the cervix is just right, but it allows one finger and short cervix, we do a sweeping of membranes to aggravate. And we are doing a sweeping, I think quite a good number of cases do start a spontaneous onset of labor within a 48 hours for that. And sweeping of membranes liberates some of these prostaglandins and rupture sweeping, separating that inside the uterine contractions for that also. There is a risk also in the sweeping of membranes when there is a vessels there, there could be a bleeding. Usually there is a small amount of spotting there, but in cases when the vessels are more, there can be a risk of bleeding for that also. ARM, as I have already told, it is a stood test of time since 2 centuries, and ARM, artificial rupture of membrane, is one of the very surgical effective way of surgical methods, and 4-water rupture for that also, and with the Cocker's forceps, or there are some globes with the thorn, and you can do the ARM with the gloves, with the finger also, you puncture that particular ARM and fluid for that. There is a risk of the cord prolapse, particularly in cases when the presenting part is not fitting well, and these are the risks for ARM. But ultimately, you have to decide on a clinical judgment of individualized cases. Now, coming to the pharmacological basis, oxytocin has been there since long, and it is still there as a very good pharmacological method for that also. And this oxytocin, the heat stable oxytocin, and therefore we say that earlier we think that only methylamine is heat labile and heat stable, but here is also oxytocin and heat stable oxytocin. I think for that we need to preserve it in the freeze for that. The dose, the titration, and the duration of therapy and combined methods of surgical, all are important in decision making and effective and result for that. The dose, conventionally the dose is usually it varies from 4 to 6 millunits per minute, and this 4 millunits per minute, if you roughly found out that 500 ml normal saline, with it add 2 units for that and rate about 16 drops per minute, this is done for that. And this titration can be done nowadays. The infusion pumps are available, and the infusion pumps can accurately titrate the dose and gradually increase the dose for that also. There are 2 methods once upon a time, either high dose 6 millunits per minute and gradually coming down, or 4 millunits per minute, and every hour you increase to 2 millunits per minute and titrate it, and depending on the results of the uterine contractions, relaxation, and the fetal heart for that. So these are some of the things which till today is important, and you must be considered for that. And don't use for hours together the duration for that. You must find out. If you decide for an indication for the induction of labor for a particular indication. And at the end of 24 hours, still it is not complete. I think revise your indication for that. And unnecessary, what I mean to say, that undue prolongation of the labor process or induction method is detrimental for that. Now, more effective oxytocics like prostaglandins have come up, PGE1 and PGA2. PGE1 is a misoprostol, PGE2 is dinoprostone, PGF12 is a strong tetanic contraction which is restricted for particularly PPH prevention and therapy for that. So PG1 is a misoprostol which is there, and this is a wonderful molecule, not only in obstetrics but gynecology. It has an expanded indication. Initially it was used by gastroenterologists for acid peptic disease, and it is off-label use particularly for gynecology and obstetrics for that. And of late the FDA has recommended this, but still I can say in many countries it's an off-label drug, and misoprostol is a really an effective drug as far as the initiation of labor is concerned for that. I will deal with that in the subsequent moments for that. The dose can be variable, and the 25 microgram of misoprostol and repeated within at 4-hour interval in the vaginal route is an optimum standard dose for that. And it started when before vaginal also, orally also we have tried for that, but vaginal is more effective for that. At that time 200 microgram tablet was available. It is very difficult to cut into 8 pieces and find it 25 microgram. Now it's available, small doses are available for that, and therefore misoprostol is also very good, particularly as a methodology for the induction of labor, particularly in a case of IUFD and the gross congenital malformation. PGE2 is a dinoprostone. We have done that, and these are there: dinoprostone gel or tablet or pessary. These are the 3 main things, and intracervical versus intravaginal. When it came in the first recommendation of PGE2 intracervical, we have used the intracervical as a process of induction labor, and we have also seen uterine tetany. I think the recommendation is there. You go with the insert, and below the internal os, in the cervical canal, endocervical canal, you deposit this particular value for that. And invariably, if it goes higher up in the lower uterine segment, I think uterine tetany occurs and fetal affection will be there for that, and that is a risk for that. And therefore, the vaginal gel or vaginal pessary is available for that also. When done, the vaginal gel or pessary is available, and the newer innovations is there where you can control the dose for that also, dose control, and you can remove it desired limit for that. As you stop in a case of oxytocin, when there is a uterine tetany, you can stop the titration method and stop the drip value for that. So dose, risk, and efficacy will be done. Now a little bit about the mifepristone. Mifepristone is also a wonderful drug which has been used combination with misoprostol for medical abortions for that. And mifepristone particularly, I have used it in my personal experience. I found, particularly in the case of IUFD or gross congenital malformation, I recommend this misoprostol or Foley's catheter mechanical with mifepristone for that. Give this mifepristone 200 microgram, only 1 tablet orally, just 12 to 24 hours prior to the misoprostol. I think the induction delivery interval will be lessened, which will be reduced to a considerable extent for that. This is my initial observation, and therefore I always prefer to give a mifepristone 200 microgram before the real initiation process by misoprostol. So this is what's new in this particular agent: minimal side effects and maximal effect we want it. It should be easy to administer, and it should be cost effective, and therefore dinoprostone or vaginal insert has become the Cervidil which is being manufactured and which is available now. This with a you can use it, and this pessary for that, and you can use this and keep it in the vagina, and 10 milligram is the dose, and every hour it liberates, and therefore there is a tail for that. If you find a uterine tetany, you can remove this tail from the vagina for that. This is much more effective and better in comparison to the intracervical dinoprostone gel for that also, because it's a within your control for that also, and it is a auto release and continuous absorption will be there hourly at a particular fixed dose for that. And this is Cervidil. So these are all oxytocin infusion for induction labor using an infusion pump. I have told that it varies from 4 to 6 milliunits per minute, and the drip rate and the titration methodology apart from these can be judged with the or without the infusion pump for that. These are the dosage regimens of prostatic preparations for induction labor: PGE2, PGE2 vaginal gel, vaginal tablet, PGE2 vaginal insert, and this particularly vaginal insert, which I have told about the Cervidil, 10 milligram released at 0.3 milligram per hour for 12 hours, and make the patient remain supine for 2 hours. Remove at onset of active labor, or this is very effective for that. PGE2 intracervical gel 0.5 milligram can be repeated 6 hours if required, but it causes, if it is gone, then it causes uterine tetany for that. Oral misoprostol is not very effective for that. The vaginal misoprostol, and a case where you don't exceed 50 microgram of misoprostol, particularly for that, and you can repeat it every 6 hours. But you must say that if it's a living fetus, the chances of birth asphyxia is more, meconium staining is more, and I have seen the incidence of silent rupture of uterus. So therefore, the monitoring is essential while using this misoprostol. Now, what is the comparison between oxytocin versus prostaglandins? Oxytocin is a poor cervical ripening agent. Prostaglandin is much better, good and better ripening agents than oxytocin. Used with IV infusion for induction labor, this oral or vaginal route, which is convenient. Stopping the infusion will stop the action. Once the action is started, it is difficult to terminate accepting this Cervidil. Less systemic side effects. It is a more systemic side effects like nausea, vomiting, headache. Can cause fluid overload with oxytocin, and no fluid overload there is there. Contraindicated in heart disease in oxytocin, but prostaglandin is contraindicated in asthma, which can. It is a less expensive is oxytocin, and whereas the PGA2 gel and Cervidil is little expensive, but misoprostol is a less expensive molecule in prostaglandins. So these are some commonly used regimens for pre-induction. If you come to the cervical ripening and labor, again this could be used as a ripening. Danoprostol gel can be used. Misoprostol can be used for that, but the dose should be 25 to 50 microgram for that, and can be repeated 3 to 6 hours interval. And mechanical, I have already told about the transcervical Foley's catheter, 30 ml balloon with or without the saline installation for that. And hygroscopic dilator, some laminuria and hydrogel tent are available now. The refined new innovations for that is also available in comparison to laminator. But I have not used it. I don't have any experience on this tents for that. So in a nutshell, I can give you induction labor. What are the indications? The maternal and fetal indications. I have already told about maternal indications: severe preeclampsia, eclampsia, intrauterine fetal death, antepartum hemorrhage, gestational diabetes, RH isoimmunization, chorioamnionitis, and maternal malignancy. Whereas the fetal preeclampsia, prolonged pregnancy and postpartum, and placental insufficiency or FGR, prolonged rupture of membranes, abnormal test for fetal well-being, past history of unexplained intrauterine fetal death, and fetal malformation for that. This is again an indication which I can say. If there is a past history of unexplained fetal death on a bad obstetric history, you find out at which gestational age that death occurs. So 1 week before that particular death, you just do an induction. There's another indication which is very common for that. And need to terminate the pregnancy. If vaginal delivery is contraindicated for some obvious reasons, then do an elective cesarean section. Vaginal delivery is not contraindicated, then you find what is the cervical status. Bishop score is more than 6 to 10, along with more than 9 to 13, or Bishop score is less than 6. Cervical priming is essential if the Bishop score is less than 6. And that can be done with either a vaginal misoprostol, surgical induction with the mechanical methods, and then when the cervix dilates, do an ARM, surgical method of ARM for that also. But at the same time, while this procedure, monitor the maternal vital signs, monitor the fetal heart, monitor the progress of labor, applying the partograph. And if it is a satisfactory progress, then it is there. You can continue that. If it is unsatisfactory progress, like poor cervical dilatation, poor fetal descent, or fetal distress, intervention is necessary and do a cesarean section for that. Now, what are the risks of induction? Uterine tetany I have told. Uterine rupture, I have seen a rupture particularly for induction. And this particular uterine rupture I have seen in the unskilled hands for initiation of labor in the domiciliary when the domiciliary delivery was there. Now institutional delivery we are not finding out. But at that time, in my early days, I have seen lot of uterine rupture. The thighs has given intramuscular oxytocin, 5 units, 10 units intramuscular for augmentation of labor and initiation of labor for that also. And I've seen that uterine rupture. And of course, there is a risk factor for rupture like the previous scar of cesarean section or the myomectomy scar. Even your normal dog, if you do not monitor, I think the rupture is there with the misoprostol. And more often, misoprostol, the contractions are, the pain is not manifested and therefore silent rupture can be seen for that. Infection most often occurs with the mechanical methods or a prolonged duration. Infection is one thing. Accidental hemorrhage, I have already told that there could be undiagnosed low-lying placenta or doing a sweeping of membranes and ARM that could bleed also. Fetal asphyxia, risk of induction is there for fetal asphyxia. As I have already told, the evaluation of the fetus should be there prior to induction of labor. Whether the fetus is able to sustain the stress of labor by, for example, find a severe fetal growth restriction, severe placental insufficiency, or a severe oligomnias. These are the cases where the risk of induction should be there. And of course, the cord prolapse is there when there is the fitting, it is the ill-fitting presenting part, and you do an ARM, the cord prolapse could be there. And last but not the least, you cannot be successful in 100% of the cases. Failed induction should be there also. And you must know that these are risk of induction. The failure of induction should be also there in some cases, and there is a risk of induction should be there. Now, the second important part I've almost covered to my best of my ability regarding the beginning of starting the definition of induction labor, regarding the indications, regarding the evolution of or history of induction labor and the different methodology, starting from the mechanical method to pharmacological method to surgical methods, and all these are enumerated along with that, and what are the indications, what are the contraindications, and what are the results for that also I have read. The second important part for the clinicians, because this is a series of solving clinical dilemmas. I think the first series one deals with the surgical skill transfer, Now the clinical dilemmas are important. How to solve the clinical dilemmas for that. In relation to this episode, I put forward the real life situation of few of my cases and ventilate to you day in and day out, you must be doing similar type of cases. I think this is very important to understand, and lessons learned from this also can be of benefit to all of us. This is a case one, primary gravida, 25 years, married 2 years, book case, normal antenatal profile in each visit with usual routine investigation. Absolutely normal, very sincere patient, and all the available tests are done by the very efficient obstetrician for that. And her EDD is on 3rd May 2024. Now, presented on 4th May 2024, crossed the date, she became anxious for that. Now, on examination, I find the normotensive, uterus 34 weeks, relaxed, vertex 5/5, FH is good. Cervical finding, cervix half an inch long, was closed. Unfavorable cervix, head at -2. And pelvis is apparently okay by clinical pelvimetry. That means the vaginal delivery can be possible. But here is the risk. It has crossed the date. So what is your approach for delivery? Crossing the date, immediately resort to cesarean section, or any other investigations you do it, whether you wait and watch, and what are the reasons for the wait and watch, or you do an elective LSCS and reasons for that. Those who believe that the presence of pregnancy is an indication for cesarean section, they will never consider all these. They'll go for elective cesarean section for that. But that is not science. That is not science, and that is not rationality for that. And induction of labor, if at all we want to have an induction of labor, what are the modalities for that? Let us trace one this. Now, this particular case crossed 1 day. So I advised the obstetric scan. The current scan, I wanted to do a detailed scan, reveals single live fetus, vortex, estimated fetal weight is 2.8 kg, AFI is 9.2 centimeter. and the date is also corresponding to the sonographic gestational age for that. And he is waiting for spontaneous onset of labor for the DFMC for 1 week. I gave an example that yes, it is just 1 week. We cannot go for 1 week more. 40 weeks post-dated 1 week. I cannot dare to go for 2 weeks earlier where we are giving it thinking that it's a term means up to 42 weeks. So 41 weeks, knowing fully well that after 41 weeks, the fetus, raised to the fetus is more often, particularly in the ethnic race of Asian women for that. And after 5, in this case, I've left it with the DFMC count and asked that after 1 week, you report to us. And after 5 days, spontaneous onset of labor with uneventful intrapartum period with spontaneous vaginal delivery, male baby of 2.9 kg and discharged after 2 days for that. So I've got a benefit of that. Even without induction of labor, you don't remember that. Without cesarean section also, waiting for 5 days, spontaneous onset of labor could be there. So waiting policy, the message is waiting policy for 7 days beyond EDD is a boon, where clinical and biophysical parameters are normal. If they are not normal, then you don't allow even 1 day for that. So because the clinical and biophysical parameters are normal, the sonography evidence is normal, color Doppler is normal, then I dare to wait for 1 week. And spontaneous onset of labor is definitely has a lot of merits over manipulative obstetrics or induction of labor for that. So in this particular case, there is a benefit of wait and watch. Case 2, primary gravida, 38 weeks. Blood pressure was 140/94 millimeter mercury, bridge presentation. Uterus torn, relaxed, bridge, frank bridge, cervix long, os closed. Sonography, single live fetus, frank bridge confirmed by sonography, AFI 6.5 centimeter, and estimated fetal weight is 3.2 kg. So what's your approach? Wait and watch. Elective cesarean section, induction of labor, and patients I decided for elective cesarean section. Elective cesarean section I decided basing on the view that she is hypertensive, bridge presentation, primary gravida at term, and oligamnius. I cannot dare to have vaginal delivery, either spontaneous labor or induction of labor could be there. I cannot have a wait and watch also. I cannot do for induction, I cannot dare for induction of labor. So only option left behind is elective cesarean section. But the patient's attendant insisted for vaginal delivery. What next? Absolutely, this is a crisis for that. But the decision, it's not a crisis. It is a straightforward decision for that. But at times, the patient's attendant creates a lot of problem for that. So what to do for that? So I decided for elective cesarean section and for term, bridge presentation, gestational hypertension and oligamnia. These are the rationality in front of me. And a female baby of 2.8 kg delivered by bridge with meconium stent like her with Apgar score 8/7 uneventful post-op period. I recollect one instance, one of my old student in a district hospital, he was practicing, is a very good practitioner for that, is a very good student for that. Once he phoned me that, sir, such a case, similar to this case he has found out. Primary gravida, bridge presentation at term and PIH. Of course, the AFI was normal. AFI was normal, bridge presentation, frank bridge, term and primary gravida and hypertension borderline 140/96 millimeter. He phoned me, sir, what is should be done? I told, is there a second option? You go for a cesarean section. Then he told that no, the party is not willing for that and how to deal with that. And you say, if it's not dealing with that, then you change the obstetrician. Yeah, I am not going to take the risk for that. You change the obstetrician. But my student is more intelligent than me. When I didn't find any call from him after 2 days, I rang him. What has happened? He told that I did a cesarean section, but I think he told me, sir, I am more intelligent than you. I could be able to convince the party in a much better way. What you did, he told, let's see, if you wanted normal delivery, I will admit the patient in the morning. I admitted the patient in the morning, started a plain drip. 20 drops, 30 drops, 40 drops, plain drip without oxytocin for that also. And then the first pint is finished, the second pint is finished. Then the party came running to him. Sir, from 12 hours you have tried a lot, but the delivery is not there. Please do a cesarean section for that. And then I did it. So I'm more intelligent than you. But I'm little non-ethical and non-scientific. And this non-scientific reason has influenced this person and convinced that for them. So this is one of the example out of the way I'm telling you. But these are the cases decision I've taken for the elective cesarean. So the message here, rational technical decision should always override patient's wish for that. We cannot accept that, even if in the era of directive practice. I condemn this particular thing. We cannot obey with the directive practice. They cannot decide our decision for that. In some cases, in many cases, you must have felt that they put pressure on us for that. And then the reverse also is there. If you go for an induction of labor, if you decide everything is normal for induction of labor, the patient's attendant say that please do a cesarean section for them. In that case, you are at a dilemma. What will do it? If you go for elective induction of labor, if there is any problem, you are subjected to problem. And therefore, there you allow for this directive practice for that, because there you can allow, but in the other case, we are not going to allow that. Case 3, G2, P1, L1, gravida 2, para 1, living 1, spontaneous vaginal delivery 3 years ago. That was the first birth, vaginal birth there. GDM, irregularly treated, presented at 34 weeks gestational age with IUFD. Pitloid is not heard, sonography, say 32 weeks relaxed, vortex 505, FHS absent, and cervix was half an inch long, was closed, head at man. So unfavorable cervix with IUFD. So what's your approach? Wait for spontaneous onset of labor. If you allow for a spontaneous onset of labor for a few days or few weeks, spontaneous onset can occur for that. But can you allow the wait for spontaneous onset of labor? The mental anticipated, I think, risk to the anticipated risk to the patient is there, mother is there, wait up for spontaneous onset. Unnecessary mental trauma will be there for that. Risk versus benefit you must find. So we go for induction of labor. We cannot do directly cesarean section, is not at all a rational decision for that. And therefore, induction of labor, what should be the modalities for that? And LACS, we are not subjecting for that also. So counseling was done, blood sugar stabilized, induction of labor with misoprostol, and with the mifepristone priming was done. 200 microgram of mifepristone, then subsequently 25 microgram of misoprostol at 4 to 6 hours interval. And spontaneous expulsion of macerated male fetus with afterbirth within 10 hours and discharged after 24 hours for that. So the message, GDM is not uncommon in obstetric practice, and antenatal screening, which we are doing in all pregnancies, and adequate control of blood sugar with preferably this insulin, optimum fetal surveillance yields good perinatal outcome, even in diabetes. But induction of labor by pharmacological method, that is prostaglandins, is rational in this particular case for that also. If somebody tries that, yes, I will give the Follis catheter, there is a little risk in a GDM, but a controlled GDM under antibiotic, this is also an option. You can give it for that. There is no doubt about it for that. So these are some of the methods, messages, which I give it for the GDM. Case 4, primary gravida, 38 weeks, gestational hypertension, blood pressure is 140 over 96 millimeter, uterus strong size, relaxed, vortex 504 over 5, cervix is half an inch long, os is 1.5 centimeter, dilated, head at -1. BISAP is little favorable. Sonography, single live fetus, 37 weeks, vortex, AFI 9 centimeter, EFW estimated birth weight is 2.9 kg with the collar Doppler normal. So it's a very keen for vaginal delivery. She insisting for vaginal delivery. So on this basis of hypertension, gestational hypertension at 38 weeks, I don't want to prolong the pregnancy for waiting for a spontaneous onset of labor. I want to terminate the pregnancy. And what's your approach with that? Wait and watch? No. Induction of labor? Yes, I will do an induction of labor. LACS, if somebody is willing to do a liberalized decision for cesarean section, they can go for that. But I didn't agree with that. And here I started with induction of labor by oxytocin infusion. 1.5 centimeter dilated and started with oxytocin infusion. And as contraction started and the dilatation is a little more, I did an ARM done. ARM done, intrapartum monitoring by patography was employed, and a vaginal delivery with episiotomy male baby of 3 kg delivered on eventful intrapartum and postpartum period. So what is the message? A rational indication of labor in PIH at term or even before with sonographic fetal assessment. Even before term also, if the sonography tells there is a oligamnias or FGR could be there for that also. Then also there is an indication for termination of pregnancy, induction of labor with antenatal corticosteroids. Here, antenatal corticosteroids is desirable in preterm babies before induction for that also. And cervical priming should be done in unfavorable cervix. And therefore, combined methods of medical and surgical is more effective in this particular case. Case 5. Priming gravida at 34 weeks, conceived following ovulation induction, 3 years of primary infertility, irregular ANC, presented with leaking since 2 hours. Normotensive, uterus is 32 weeks, relaxed vortex, FHS good, PV cervix is half an inch long, or spatulas, frank leaking, and clear liquor draining. It's not meconium. What's your approach? 34 weeks, conceived following infertility, and leaking for that. Wait and watch, induction of labor or LHCS. Let's see what I have done. Obstetric sonography revealed single live fetus. I did a scan to find out the existing liquor in a leaking. Single live fetus vortex at 32.3 weeks. AFI, some amount of liquor is there. If it were a gross or severe oligamnias, 4, 5 or nil oligamnias, then things would have been different. I would have done for a straight cesarean section. Here AFI 7.6 centimeter. EFW estimated fetal weight is 1.9 kg. I gave an antibiotics, broad spectrum antibiotics with betamethasone, 24 milligram given. Ideally 12 milligram at 24 hours apart we should give it. But in some cases also like this, I give it 12 milligram at 12 hours apart from that. And don't wait because I don't want to wait more than 24 hours. Because I expect that if at all spontaneous onset of labor occur, that occurs within 12 hours to 14 hours for that. So if no initiation of labor within 24 hours. So cervical vaginal pessary was administered and the vaginal delivery within 6 hours occurred. There is no tetany and preterm female baby of 1.585 kg with Apgar score, optimum Apgar score of 8/10, and the baby need not be transferred to the NICU. With the managed with the warmer in your own conventional unit with the beside the patient for that. So what is the message? Preterm premature rupture membrane and PROM are not uncommon in obstetric practice. Clinical parameters supported by sonography aids to rational decision. Amount of liquor had to be decided. Antenatal corticosteroids and antibiotics improves perinatal outcome in this particular case. In a case of preterm premature rupture of membrane, the controlled delivery system, Servitil, an innovative method, a prostaglandin and E2 is a very good method for them. And avoidance of cesarean section by induction of labor could contribute to decreasing primary CS rate for that. So here is an example of the message after this particular case. Case 6, G2, second gravida, para 1, living 1, first spontaneous vaginal delivery, 3 years and 38 weeks with pain abdomen. For last 24 hours, admitted in a PHC and referred to our unit with a sonographic report of single live fetus 37.5 weeks, buttocks AFI 10 centimeter, EFW 2.9 kg. On examination, I found uterus was storm size, irritable, vortex, FHS was good, but uterine contractions was not optimum. It is the uterine inertia. Cervix fully faced or 3 centimeter and membrane was applied, head at -1. Now, this particular case, what's your approach? Wait and watch. Intervention modalities, you cannot wait and watch. And intervention, either a cesarean section or induction of labor or augmentation of labor. Here the pain is there. Initiation of labor is there, so that the cervical dilatation is up to 3 centimeters. So augmentation of labor with oxytocin along I've done, and along with ARM, same time, 3 centimeter I did an ARM, and clear liquor, I could see that there is a clear liquor. I was more hopeful and I was relaxed with that and started oxytocin following that. So here I did first ARM and then oxytocin. Labor progress by patography. Vaginal delivery of a male fetus weighing 3.2 kg, uneventful intrapartum and postpartum periods was there. So the message, augmentation of labor very often necessary to avoid prolonged labor. And oxytocin is the drug of choice. ARM gets a better efficacy and shortens the duration of induction delivery interval. Case 7, primary gravida, 30 years, severe preeclampsia at 36 weeks gestational age. Blood pressure was 160 over 116 with proteinuria. Uterus 34 weeks, relaxed, vortex, fetal heart was good. Parietal edema, pedal edema, triple plus, PV examination cervix 1/4 inch long, or 2 centimeter dilated, head at -1. Obstetric scan, single live fetus, 35 weeks, AFI borderline 8.5 centimeter. Estimated fetal weight is 2.7 kg. Color normal. What's your approach? Induction of labor? Yes, we can go for induction of labor or emergency cesarean section. Again, there could be a valid reasons for elective cesarean section, emergency cesarean section in this particular case. I don't deny. It's also rational for that. If somebody decides induction, he is also right. If somebody decides emergency cesarean, he is also right. So I decided for an ARN followed by oxytocin infusion. And along with that, because it's a severe preeclampsia, Maxolf as an anticonvulsant therapy and nifedipine as an antihypertensive therapy started. Vaginal delivery within 7 hours. Female baby 2.7 kg delivered. Apgar score is 7/10. Discharged after 4 days with the control of hypertension. And this is a rewarding case. So message, termination of pregnancy is the definite treatment for severe preeclampsia. There is no way of continuation of the pregnancy. So the definite treatment is severe preeclampsia. Maxolf and antihypertensive measures has a definite role and ancillary role. It's not definite treatment. Early ARM is beneficial because it reduces the induction delivery interval to a great extent for that. Case 8, primary gravida, booked case at 40 weeks plus 2 days. Normotensive, uterus storm size relaxed, vortex 4/5, FHS good, cervix half an inch long, os closed, head at -1. Pelvis clinical perimetry is okay. Sonography, single live fetus, 38 weeks, vortex, AFI is 10 centimeter, and estimated fetal weight is 2.9 kg, and she was keen for vaginal delivery. She has crossed the date, but 40 plus 2 weeks. Then I planned for vaginal delivery with an induction, and plan was cervical priming because cervix was closed, cervix was 1/4 inch. Cervical ripening done with the dinopristal gel, cerviprime, within 15 minutes of application. It was intracervical and there is a uterine hypertonus, FHS bradycardia, irregular heart, and injection torbitalin was given, 1 ampoule given, and atrociban was given 1 ml, 0.9 ml was given, IV directly with 5 ml normal saline, and uterus, although relaxed, we cannot wait for normal thing for that because of the risk of post-dated pregnancy, because of the risk of this hypertonus and the fetal heart rate. So emergency LSS was done, term male baby with meconymst and liquor, mother and baby okay. So therefore, I always emphasize 24/7 emergencies should be there for that also. You cannot be assured that once you start induction of labor, you will be successful in all cases for that. There could be many things in between that, and what's wrong and what's right, you imagine. But message, therefore, uterine tetany and hypertonus are complications of intracervical PGE2. Immediate uterine relaxation should be given, either a torbitalin or atrociban is effective, but urgent delivery by LSS is rational for that. It could be the relaxation of the uterus could save the baby, but ultimately immediate cesarean section will be important for the fetal sake, and vaginal PGE2 is a suitable alternative. Seeing with that, intracervical dinoprostone gel, we have almost abandoned this and giving rise to the vaginal the dinoprostone gel or pessary like Cervidil to avoid this complication. We have learned a lesson for that. Case 9, primary gravida at 38 weeks, booked case, presented to labor with pain abdomen for 24 hours. Single live fetus, vertex 4/5, contraction 1 to 2 per 10 minutes, relaxation good, fetal heart good, cervix 1/4 inch long, all segments stiff, head at -1. And therefore, with the clinical parameters of normal, there is the contraction is less, uterine inertia for that, and therefore, augmentation of labor was done with misoprostol 25 microgram vaginally, repeated 4 hourly. Vaginal delivery after 10 hours, but asphyxiated baby of 2.7 kg with deep meconium stent Leica could not be revived. This I have seen in one case particularly for misoprostol. And what's wrong and what's right? I think misoprostol for induction labor is effective, but incidence of birth asphyxia is more common for that. So therefore, I always recommend this misoprostol for gross malformation or in a case of dead fetus for that. And therefore, misoprostol induction labor should be very selective, and 25 microgram with strict monitoring. It can be given also. There are a lot of centers where they're very popular for that also. But I prefer that you should have an optimum monitoring for that. As and when required, you just do an interference for that also. So these are the messages which I can give it for that. Case 10, primary gravida at 38 weeks, gestational hypertension, 142/96 millimeter, uterus storm size relaxed, vertex 4/5 FH is good, cervix half an inch long was closed, pelvis is okay. She is keen for vaginal delivery. And the other methods we find that yes, plan for Foley's catheter 16 gauge intracervical with 40 ml saline, kept for 24 hours. No significant progress. Then oxytocin induction failed, oxytocin given, but still oxytocin and titrated dose for 1 hour didn't give any result for that. And therefore, after 36 hours, LSS was done. Term female baby with light meconium stent Leica revived for that. And what's wrong? It's a DB, and baby was living, post-operative period was normal for that. So what's wrong and what's right? The message induction labor in PIH is very rational. Mechanical and pharmacological methods failed both in this case, and immediate intervention was done. LSCS. It is a rational decision because it's a obstetric unit with a good team for that. Therefore, obstetric units with 24/7 emergency services with NICU facilities are desirable if you are going for the induction labor by any methods for that. This I always say that failure could be there. It could be various reasons could be there for that. But intervention should be optimum at the right moment for a optimum perinatal outcome and maternal safety. Now, take home message, therefore, I can say genuine indications clearly benefit the mother and unborn fetus. There's no doubt about it. Assessment of inducibility scoring is essential for successful induction. And wide range of methods are available. Selective use by individual judgment is necessary for that. Optimum fetal monitoring is the need. Throughout that need of fetal monitoring, maybe CTG constantly could be a valuable tool for that. Prevention and early recognition of complication is necessary before some drastic event occur, and you must intervene at that particular moment. And a dedicated obstetric units with facilities for 24/7 emergency and optimum NICU facilities are desirable for that. And of course, these are paramount important. Whatever methods you do it, and mindset of the patient is important. The mindset for vaginal delivery, I will be a mother, I will bear the pain. Mindset of patient, ideal methods, and tricks of obstetricians and midwife. Applying this, which method to which particular patient is the key to success. So the future is ahead of us. Artificial intelligence in decision making will come in the near future for that. It has invaded every field, and medical faculty is not an exception to it. And artificial intelligence have been used particularly and will be more pronounced in the near future in decision making. In decision making could be there also, because this particular case, artificial intelligence will tell us whether you go for vaginal delivery, spontaneous onset of labor, whether you go for induction of labor, whether you go for a cesarean section, which method you use it in which case, obstetrics is very simplified in that method. You don't have to apply for that. So digitalized and computerized methods in initiating uterine contractions and ripening of the cervix could be there for that. There could be soft, I think, part for that. Computers and electronic technology could be a software, could be there, which can ripen the cervix, and a digital or chip technology could be there, which could initiate uterine contractions, and sensors, multiple sensors could be there, and multiple monitoring could be there, and we apply a sensor, and the sensor tells that yes, fetus is okay, life is only 7 days, life is 7 hours. They could decide, and that could be thoughts of the future, where our human brain, in addition to supplemented with artificial intelligence, can do really alarming situation and can do really obstetric very easy for that. Obstetrician's thought and obstetrician's future could be very simplified for that. And then I think the things will change. In the near future, this could be there. Some newer innovative molecule might come, but this is definitely, I wish that artificial intelligence could really improve our human intelligence and supplemented it, which results in simplified obstetric practice for that. Thank you very much, ladies and gentlemen, and my dear viewers, for keeping me interacting with you for about a couple of 2 hours or more for that. Thank you very much.
Thank you very much, sir, for very informative and engaging session with real world examples. Thank you very much, sir. With your permission, there are a few questions we can take.
Yeah.
Yes. So the first question is from Lavanya. She is from Kannadi. When to start cervical ripening agent and use the inducing agents? So
cervical ripening agent, I have told that there are 2 factors. One is irritability, irritation, so the muscular contractions is one, and second is ripening of the cervix. So cervical ripening agent is only in a case of a low Bishop score, and cervical inducibility score is less, then you apply the cervical ripening. Say preferably less than 6 for that.
Yes, sir. So the next question is from Hema Warrior. She is from Palakkad. What is the current stand on elective induction at 39 weeks?
Yeah, there's a lot of literature. Thank you very much for the beautiful question you have raised for that. I think there's a lot of literature and a debate between elective induction, routine elective induction at 39 weeks, even if everything is normal for that also. So there is a lot of debate for that. The benefit of this 39 weeks is that as we go, we know that in Asian women, the 39 weeks is at optimum time. 1 week earlier, fetus matures, and therefore the days, every day we prolong it beyond the date, the risk to the fetus is more. And that is the only indication, rational indication, where I will support elective induction for that. But on the other hand, majority of the cases of elective induction would have gone for a normal spontaneous onset if you wait for 1 week for that. And that's one. Second important, I've already told, natural onset versus pharmacological onset, there is a lot of difference for that also. There are many literatures which says by induction of labor, we can reduce the cesarean section rate for that also. And there are some literatures we can show that elective, the induction of labor versus natural, I think the increased incidence of cesarean section could be there for that.
Yes, sir. So the next question is from Jammu.
In induction.
Yes. So, sir, next question is from Jammu. Dr. Jyoti Haq. She is asking the role of induction in patients with 2 or 3 turns of cord.
Well, this is really nowadays after sonography and evaluation of the nuchal things is there by sonography and accurate identification and demonstration of the nuchal position of cord around the neck. I think it is alarming to the patient. We earlier knew that majority of the cases, in 50% of the cases, we find a cord around the neck, single or twice around the cord for that. But nowadays, the demonstration of that, even if single round of cord, patients are panicky for that. And they see that the cord entanglement will be there for birth asphyxia for that. We have seen many cases that multiple rounds of cord, short cord, these are the causes which is there for creating problem when the labor starts for that. Otherwise, majority of the cases do not have any problem for that. And you counsel the patient that cord round the neck is not a factor for cesarean section or induction labor for that.
Yes, sir. So, Dr. Tripura Sundari from Hyderabad, she is asking, will induction of labor increase the incidence of amniotic embolism?
Yeah. There is books have written also that one of the complications of induction of labor is amniotic fluid embolism. Now, this is to me, it appears more theoretical than practical. Because when amniotic fluid embolism, when we do not find any cause in a maternal death, we diagnose that this could be cause of death is due to amniotic fluid embolism. It's very easy to tell that amniotic fluid embolism, but to prove amniotic fluid embolism is difficult entity for that unless you do a post-mortem and finding all these criteria for that. So therefore, when there is a maternal death, I keep amniotic fluid embolism as the last thing. Virtually I don't accept amniotic fluid embolism for that also. But there are cases where this has been reported, and it is more often when there is a polyhydramnios, and amniotic fluid embolism could be one of the reasons for that. But it is a vague term for that. I don't believe in this.
Yes, sir. So the next question is from Delhi. Monica Jain, she is asking, are there changes in the new labor care guidelines for induction of labor?
Yeah, the WHO guideline is there. The NICE guideline was there in 2006. They have given a new guideline for the induction of labor. They have a separate book on that, a NICE guideline which have been given. But WHO labor care guide, there is some description of the induction of labor, but the whole process is dealt with the labor process, not with the specific of induction of labor.
Yes, sir. So Dr. Sangeeta Trivedi, she is asking the induction in eclampsia or severe PIH.
I have already told that severe PIH and eclampsia, the definitive treatment, there are three types of modalities of treatment. One is a termination of pregnancy, anticonvulsant, antihypertensive. The most definitive treatment of hypertensive disorder pregnancy is termination of pregnancy, because Pritchard has shown that in some way, in some mechanism, the presence of chorionic villi incites vasospasm. We do not know for that. So therefore, this chorionic villi, when it is gone, I think this is controlled with that. And therefore, this severe preeclampsia, we cannot continue the pregnancy and we must terminate the pregnancy. The question appears whether you go for induction labor or you go for a cesarean section for that. That will depend on the individual judgment of that particular case. You can go for ARM and artificial rupture of membrane and oxytocin dip and aiming at induction labor for that, or you can go for a cesarean section. But termination of pregnancy is the definitive.
Yes, sir. So, sir, last question from Champa. Dr. Atul Rathod, he is asking 12.5 microgram misoprostol plus 2.5 unit oxytocin plus Foley's catheter. Is this combination is better than any single? Yes, sir.
So this is a cocktail methodology in ARM. 12.5 you combine with misoprostol, with oxytocin, and with Foley's catheter mechanical, all mixed with that. I don't have any experience on this particular the combination methods for that also, but this could be, I can't reject it completely, because in Indian brains are something superior. Indian brains are jugaad brains. You can have a lot of jugaad with that also, and you do it paper and find out and supplement it. I will welcome that.
Yes, sir. Thank you very much, sir.
Thank you, Sanjay.
Thank you.
Thank you, Brushali.
Thank you, sir.
And thank you, Sefali, for that. And the whole team of Juventus, I think, will continue with this effort.
Yes.
Yes, sir.
Thank you very much for your response and very sincere devotion to this particular E-Gurukul program. And for the benefit of my viewers, for the obstetricians across the country, as a teacher, I will continue to do this till my last breath. There is no doubt about it. Thank you very much.
Sir. Thank you.
Thank you, sir. Thank you. Yeah, so stop recording.